So, so that everybody understands, in the spring of every year, CMS puts out the final rule for home health, and well, in all the other industries too, health industries, but for home health, it comes out in the spring, and then agencies have 60 days in which to review it, to decide on what, to ask questions, to make comments. I like this, I don't like this, and just really give their opinion. And so once that 60-day period is up, then CMS takes it back again, and they review it again, and review all of the comments and the suggestions, and then they will put out the final rule. And once this comes out, this is it. This is what will be in effect for the calendar year of 2018. So why is it, though, that we're so intent on getting it now? Well, today was actually the drop-dead day that we could get it for next year, because there is a mandate that says that anything that's going to go into effect in the from the Federal Register has to be published at least 60 days before it goes into effect. So if you count from today to January the 1st, when this rule becomes effective, today is day 60. So this was the absolute last day that it could be there. So we knew it would get there. We just didn't think that it would take this long to do it, because a lot of times it's out a couple of weeks before that date. So the provisions that were included, and as I'm just going to give you what the provisions are, and then we're going to talk about them separately. So there's updates in the home health, the HH PPS system, payment rates, including the national standardized 60-day episode rate, the national per visit rate, and you know, as that you do if you're going to have a LUPA, and the non-routine medical supply conversion factor, effective for episodes of care ending on or after January the 1st of 2018. So if you have an episode that is going to end on January the 1st, all right, the new rates, if the last day of the episode is January the 1st, the new rates for 2018 apply. Now, if the episode ends on December 31st, it's going to be the 2007 rate. So make sure everybody understands that. Updates this rule updates the home health PPS case mix weights using the most current complete data available at the time this rule was made. Implements the third year of a 3-year phase-in of a reduction to the national standardized 60-day episode rate to account for case mix growth between 2012 and 2014. So CMS announced this several years, well, 3 years ago now, because this is the third year. They're reducing it because of that, and we're in the last one. Now, there's not to say that, excuse me, next year they won't extend it, because that's what they did with case mix creep. They originally told us it would be 3 years, and then I think it finally extended to like 6 years eventually. All right. This rule makes case mix methodology refinements, as well as a change in the unit of payment from the 60-day episodes of care to a 30-day period. But we'll talk about that. That they were hoping to implement in January of 2019. But again, we're going to go, these were just the provisions that were in there. We'll talk about what's going to happen with that. They made changes to the home health value-based purchasing model and to the home health quality reporting program. So here's what's happening in the payment update. First of all, they're estimating that with all the payment updates that it's going to be in here today, that the net result of all of that in this proposal is an $80 million reduction in Medicare payments to home health agencies in 2018. $80 million. So for the calendar year of 2018, the market basket percentage increase shall be 1%. So you're basically, that's what's happening. You're getting a 1% raise, and so that's $190 million. So some of this, eventually, washes out. So $80 million reduction just off the top, and then you're getting a 1% increase, so $190 million. But then there's a 0.97% adjustment to the national standardized 60-day episode rate to account for nominal case mix growth. That's that third year of the 3-year impact. And so that's a $170 million decrease. So you can see that already you're in the negative there. But the base episode rate for 2018 is set at 30.39.64. And for all updates, for everything we're going to talk about, because I'm going to go over some of these in more detail in a minute, for all of these that we're talking about, agencies will risk losing 2% in their next year's payment update if they fail to submit the quality data. So some of you may remember it was originally 70%, then 80%, and now it's up to 90%. That's how much of your quality data you have to submit. Now, let me just say this. For agencies who submit all of their OASIS, you're never in jeopardy of not doing that. But just so in case you're not one that submits everything, maybe it's not, you're not submitting it to Medicare because you don't need it there. It's not a Medicare payer. All right. So in order to understand what some of those are, I want you, now in your handouts, for those hopefully that you printed them. Oh, by the way, as Rob mentioned, your handouts are there, but also there is a link to the final rule in that that he gave you also. So make sure that if it's a 300-page document, but you put it on your desktop, there may need to go back and reference some of the things that we're talking about today. So this slide here is really just a clip of Table 2, which is I think it's a 2-page document. And so this is, for those of you that's never seen this, this is probably something that I use every day. And if I'm just trying to figure out, because you could actually figure out your own scores, even I know your software does it, but you can also figure out your own scores from this document. The whole document, like I said, is either in the link to the handouts, or you can get it out of the final rule also. So it's called Table 2, Case Mix Adjustment Variables and Scores. And the way this is read is that the numbers across the top, the one that says 1 or 2 or 3 plus, that is the episode of care. 1 or 2 is the first or the second episode of care, and 3 plus is the third or greater episode of care. All right, and so those are looked at. You looked at those by equation: 1, 2, 3, and 4. And then a little bit more with that one is that early episode with 0 to 13 visits is in equation 1. An early episode, a first or second with 14 or more, is equation 2, and so on and so forth. So once you know that, you need to know, is this an early episode? Is it a late episode? And how many therapy visits? And then from there, you can choose the column and know which column your points are coming from. So this just tells you that, for instance, if I have a primary diagnosis of diabetes and I am in an early episode of care, let's say the first or the second, you'll notice that you are getting no points for that diabetes. A lot of change from the way it used to be years ago when diabetes was such a payment item or diagnosis. Now, if you're in an early episode of care and your patient is getting 14 visits, then you get 3 points for that. So the reason I wanted to put this on here, because those of you that's familiar with this can now go back and compare it to the old one from the 2017 year, and they're actually taking a few points away from you in some places. So where this 3 is right here for the second equation on diabetes as primary, there you were getting 4 points before, and you were getting 2 points in equation 4. Now you're only getting 3 in equation 2 and none in equation 4. So, and here's another one. Let's look at number 6 here, where you, on this second episode where you're getting 16 points, you were getting 18 before, and where you're getting 10 points, you're only getting 12 points. So what this tells you is that it will take a little bit more now to get from a C1 to a C2 or a C2 to a C3. So that's how you kind of look at this. You go down this list and decide how many points you're getting for your different diagnoses and for your other questions that contribute to your case mix, and then you will know what your scores are. And once you have that, once you know how many points you got on clinical, you see this right here says clinical dimension. As you look at the other sheets, there's one for functional also, so you know how many points you got. So once you have that, then you have this table here, which is table 3, and this tells you the threshold. So the equations are exactly the same, first and second and third or greater, and then you actually have something that comes into 20 plus. But let's look at this. So if you saw how many points you got for your different answers on table 2, then you can come to this form and say, okay, so I got 3 points for my diagnoses, all right, and nothing else for in clinical. I didn't get any other points. Patient doesn't have any wounds. She doesn't have any pain. She doesn't have any dyspnea. I got 3 points there. So that means I'm going to be at a C2, all right? And under the functional dimension, I got 14 points, then I'm going to be at an F2. So this kind of gives you an idea of how your points are scored here. This is always very interesting because people sometimes want to know, they'll say, but I changed the answer on pain. Why didn't I get any points? Well, I mean, why didn't my HERC score change? Well, you can see that if you're already at 4 points on clinical, it doesn't matter what answers you change. I mean, you want it to be correct, obviously, but it doesn't matter which answer you change. 4 or greater is a C3. You can't get higher than a C3, so that's as much as your HERC score is going to go up. Okay, so that's table 3. Now, along with some of the other equations, I mean the changes that they were talking about. So remember, I told you that your national standardized 60-day episode payment was being increased. So don't even try to figure out, unless you're one of those numbers person, you can figure out all this calculation in between. What's interesting to me is that in 2017, your national standardized 60-day episode payment rate was $29.89.97, and then this year it's going to be $3,039.64. So you got a few dollars increase in that. And that in between is just telling you how they got to that. So, and so again, so that everybody understands this, this is a standardized payment. So that means if I am in Massachusetts and I have a patient, let's say a particular, with a particular HERC score, and my payment was, let's say it's C2, F2, S1, or whatever, that doesn't really matter. And I also have that a patient with that same HERC score in California, then the national standardized 60-day episode payment rate is going to be the same. What makes the difference now is where you're located, because your CBSA makes a difference in that, and maybe also your non-routine supply will play a part in that. So, but the standardized rate, everybody sees the exact same thing, all right? So that's what this chart here will tell you. Now, this is the national per visit payment amounts for our agencies that submit the required quality data. I didn't put the chart in there for agencies that don't submit the quality data, but it's, remember I told you in the beginning, it's 2%. It's going to be 2%. So on this one, here's what, this is your per visit rate. So not that this is what they pay you unless it is a LUPA, but if the episode is a LUPA, this is how the payments work out. So if you'll notice, for the 6 disciplines, then this is your calendar year 2017, what the per visit rate was, and what it is going to go to in 2018. So again, maybe about a 50-cent raise in some of them for that rate. So obviously this is not what you pay your staff, but this is what CMS will pay you if you bill them per visit on a LUPA. All right, and then the last one of the charts here is the non-routine payment amounts for agencies that do submit the required quality data. And again, on this one, if you do not submit your quality data, then you risk losing 2%. And there would be 2% from this also. So this is your non-routine supplies, where you fall. What will determine how much non-routine supply money I will get for a particular patient. So every patient will go into a severity level. And so as you're entering your OASIS, it is in the background, and your software does that for you, is calculating your points, your non-routine points. And depending on where it is, so you will notice that 0 points is severity level 1, so that's $14.31. Again, that's a few cent raise from last year also, but that means that every patient gets at least that amount, $14.31. And then it goes all the way up to a 6, which is $558.16. So basically what that means is that it doesn't matter how many points you get after 99, that this is the most that you're going to get on non-routine reimbursement, non-routine supply reimbursement. So again, this is happening, and all, you don't have to do anything to do this, get this calculation. Depending on how you answer your questions, you know, how you answered the wound question, how you answered the diagnoses, what diagnosis, it will tabulate these points for you. Your grouper will tabulate these points, put you into one of these relative weight categories, and then assign the reimbursement for you. Okay, we'll move on. All right, so case mix creep. I mentioned this earlier. This was up until this past year, 2000, well, again, it started, gosh, I think in 2012, and then they extended it a little bit, and they extended it through the 2017 year. But there's no, good news is there's no further case mix creep adjustment beyond where we are now. In the reduction of 0.97% is what we had. CMS believes that there has been an increase in the average case mix weight unrelated to changes in patient's condition. They still believe that. But there's no added adjustment that's going to be imposed. And what they mean by that is that they think that agencies, I mean, I'm going to be blunt about it, they think that agencies just actually know how to get their case mix weight up by entering particular things, so they try to get their weight up, and that's what they call case mix creep. So they did an adjustment to try to normalize that, and that everybody, that, you know, there is not a lot of incentive for just trying to always make your patient one higher, one higher, one higher. Now, they will never rule out the fact that there could be further adjustments next year. So just because they're said that they're not imposing it in 2018 doesn't mean they can't come back next year and impose it. All right, outlier payments. So they'll keep the same 80% loss ratio that has been used since the beginning of prospective payment system, and the fixed dollar loss ratio at 0.55. This provision will affect the number of episodes that qualify for outlier payments. And CMS believes that such a change is needed to keep outlier spending within the 2.5% spending limit. So some of you may remember that a few years ago, outliers were just rampant out there. That agencies, there were some agencies that just had, you know, 70%, 75% of their patients were as an outlier, and that meant that they could get that actual recalculation and get much more money than what a regular episode was being charged. And so CMS finally got wind of that and realized what was going on, and so they capped out outliers, that no more of your revenue could come from outliers, no more than, say, 10% is what they originally said could come from outliers. So it doesn't give people the incentive to just make this patient be an outlier, because it really doesn't benefit them anymore. And you can definitely get, it will definitely send up a red flag, and you can get penalized and, you know, a lot of other problems, sanctioned and all kind of thing, for having a much more outlier patients than what other people are. And outlier patients, again, just means that it falls out of the norm, that the cost to take care of a particular patient far exceeds what your reimbursement is going to be. And you usually see that in twice-a-day diabetic patients or twice-a-day wound care patients. There's no way that you can, if you have to send a nurse twice a day, every day for 60 days, there's no way with a regular reimbursement that you could recoup the money, all right? But if that is the case, when they see how much that episode cost you compared to what your normal reimbursement was, they recalculated it so that to give you more money. But it was never intended to be a money-making thing. It was really just intended to cover the cost for all of the extra visits. Unfortunately, some people got greedy and they were making it a money-making thing, so everybody was becoming an outlier. Okay, so that's enough of my rant about that. All right, so now let's talk about LUPAs and non-routine supply update. LUPAs, which are the low utilization payment episodes that occur as the only episode or as an initial episode in a sequence of adjacent episodes, or adjusted by applying an additional amount to the LUPA payment, 1% before adjusting for area wage differences. So those per visit rates is what really applies here. All right. So again, and lupus or the 4 or greater, 4 or less visits in an episode. And so it means if it is the only, if it occurs as an only episode, meaning that, or an initial episode. So maybe you admitted a patient knowing they were only going to need 3 visits, and that's it. So that's the only episode. Or you had an initial episode in a sequence of others, but that first one was a LUPA, then they will apply that additional 1%. All right, non-routine medical supply rates are adjusted by 1%. That was that severity rating 1, 0 to 6 that I told you about, that goes from $14 to like $500. And then the non-routine supply conversion factor, just how they calculated those scores. In 2017 was 5250, and in 2018 it's going to 5303. HHGM. So I put this in here because everybody, I think that's for those people who was waiting on the final rule. They were waiting to hear this. They really wanted to find out what was going on here. So HHGM was a new payment model that CMS was proposing. Home Health Groupings Model was proposed to begin for home health periods of care beginning on or after January 1st of 2019. But it was going to be in this final rule, all right? Because the findings from the Affordable Care Act suggest that the current home health payment system, which is the prospective payment system that we have right now, discourages agencies from serving patients with clinically complex and or poorly controlled chronic conditions who do not need therapy services but require skilled nursing care. So imagine those patients, again, they are chronically ill, you have trouble discharging them because they're not getting any better. And in fact, most of them, a lot of them get worse, but they don't need therapy. Now, if you need therapy and you add therapy to their care, then your reimbursement goes up based on how many therapy visits you have. But if they didn't need therapy, doesn't matter what you did, you could do as many nursing visits as you needed to take care of that patient. Your reimbursement just never went up. So in fact, most agencies were losing money. All right. So that's what this model was designed to do, to stop giving people an incentive to add more therapy just to get more money, but to take care of the patient based on their clinical picture and their comorbidities, and to take it into account that they may not get back. So it's important for everybody to know, in case you've heard about that. But in this rule that came out yesterday, it says, while not totally ruled out for later implementation, HHGM will not be implemented in 2019. So it may come later, and so some of you may have heard it mentioned in the context of CMS, home health going to 30-day episodes. Well, you actually still have a 60-day, you would still have a 60-day episode, but you would have 30-day payment periods within that 60 days. And the point is that they think most of your visits are done in the first 30 days. So, but people tend to drag out or stretch out their visits until 60 to keep the patient the whole episode. This model would certainly discourage that. So I put it in here just so in case most of you have heard about it, you'll know now that it was not in the rules. So it will not go into effect in 2019. All right. So let's talk about home health quality reporting. Home health quality reporting has gotten so huge in the last few years because we're talking about, just your regular home health compare stuff, but also we have star rating that looks at all of our outcomes. We have value-based purchasing, and so much of that is going to affect our reimbursement in the coming years. So some of this, again, is for future use, but it's in this rule, so I needed to mention it. Beginning with the calendar year of 2020, so y'all can start getting ready for this, CMS is adopting 3 new measures that meet the requirements of the IMPACT Act. The IMPACT Act was an act of 2014 that said that there needs to be some uniformity between all outpatient services, because everybody was looking at something different. A nursing home was looking at different measures, and home health at something else, and hospice at something else, inpatient, outpatient rehab something else. So they needed, the IMPACT Act said that there had to be some uniformity between some of these items so that we can really all be on the same page. For those of you that do the OASIS, you'll know that's actually how we got that GG item on the OASIS, because that's something that the other outpatient settings use. So we needed to make sure, and that's also the reason why we used to be able to say that a stage 3 or 4 pressure ulcer that had closed was still there because it was compromised. Well, as of last year, we can't say that anymore. A 3 or 4 that closes is considered healed, because the other post-acute settings looked at them as healed once they closed. So we needed to be able to look at that. So they're making some, they're doing this. They are putting this in here: changes in skin integrity, post-acute care, pressure ulcer injury. So that's going to be something that everybody is going to have to do, all outpatient settings. Application of the percent of residents experiencing 1 or more falls with major injury. They're going to be tracking that. And then the application of percent of long-term hospital patients with an admission and discharge functional assessment and a care plan that addresses functional. So everybody's going to be looking at that. Okay, OASIS changes. So some of this we anticipated might happen with the HHGM, but now even without that, we know that this is what's going to happen. So we can expect another new OASIS next year by this time, because it'll go into effect January 1st of 19. So removing 235 data elements from 33 current OASIS items. And again, that becomes effective on January 1st. There, if you actually look at, oh, here, actually I have it down here. A list of the items being removed can be found at this web page that's sitting right here. So why are they doing this? Well, they've said that these OASIS items, or data elements within these OASIS items, are not needed to calculate either quality measures or for other purposes unrelated to it, meaning payment, survey, home health, value-based purchasing, or care planning. So they're going to take these out. I mean, you know, there's a zillion in there, and you can't just keep putting items into the OASIS and then not streamlining it. But that's really what this is meant to be. So again, if you want to look at what those items are, then you can go to this website that's listed here. All right. So now let's talk about value-based purchasing. So value-based purchasing, you know, it is currently going on in 9 states, and it is a way for agencies to get paid based on value. It's not much different from commission in sales, that the more sales you make, the more money you make, right? So we try not to look at our home health as, you know, as that, but we have to know that if we can prove that the care that we are rendering, because of the care we are rendering, our patients are getting better, they've got better outcomes, then those agencies will be reimbursed a little bit differently from the agencies whose patients either remain the same or they get worse during an episode. So that's where the value-based purchasing came from. So 9 states, and the first payment will be realized in January. And when I say payment, I'm talking about that depending on where you score on your value-based purchasing, what kind of score you get, you can get anywhere from 3 to 8% of, in the first year it's only $3, I mean 3%. 3% increase in your reimbursement, but likewise, you can, if you fall out of what, well below what the average for that particular measure is, then your agency risk losing 3%. So again, the 9 states that has been in that pilot program will, in January, either receive 3% extra or they will be fined 3%. So you may think, well, 3% is not a big amount, but you think about the agencies and just kind of, you know, multiply that. you know, depending on what your average reimbursement is, and 3% could actually be a really big number. So CMS said in the beginning that value-based purchasing was a budget-neutral program, so that they're not actually paying for it, we are paying for it. So if however many agencies, there is a mean level that is set, and depending on how whether you meet or exceed that, whatever that measure is, then your agency will receive the 3%. But if you fall well below what the mean is for that particular measure, then you will owe 3%. So why is it important to look at it now, even though every state is not in it? Because you actually, it's a 2-year period walking up to that. The first period is just kind of your base period, that they're looking at all what your data is. And then the next year is the actual payment year. So for those agencies that's involved in it now, 2015 was, 2016 was their base period. So they're looking at what all their data was, and 2017 is actually their payment year, meaning in January they will be paid for what they're reporting in 2017. So why is that important to those of you that's not in value-based purchasing? It's because if they decide, say by 2020, that every state in the nation will go into value-based purchasing, they're going to go back 2 years to start collecting your data. So you have to have it right before you actually get there. All right. So the specific goals is to provide incentives, again, for better quality with greater efficiency, study new potential quality and efficiency measures for appropriateness in the home health setting, and enhance the current public reporting process. So while you will get the incentives, again, for increasing your reimbursement, you also can be penalized for not meeting, again, that particular measure's threshold. All right. It requires that all Medicare certified agencies provide services in the 9 states participate in the model, and that there is no selection bias, that participating agencies are representatives of the agencies nationally, and there is sufficient participation to generate meaningful results. So in this measure, the 9 states are in this value-based purchasing model. In these 9 states, you don't actually have a choice. Some people may remember the pilot study they did a few years ago called Pay for Performance, and you actually had a choice of whether you wanted to participate in that model or not. This one, you don't have a choice. If it is being done in your state, every Medicare certified agency in that state has to participate. So they're going to collect your data regardless. And then again, in the following year, then you will know, I mean, there's quarterly reports, you know, getting up to the payment year, but everybody needs to be aware of those. For performance year 3, they're proposed to eliminate drug education on all medications provided to patient caregiver during all episodes of care from the applicable measure. So this would not happen until next year anyway. So, you know, we'll be back next year and tell you whether, because they could, I mean, it's in the final rule for this year, but they could change their mind and say, you know what, no, we decided we're going to leave that measure in. For right now, it still is, though. All right, so some of these things are still some considerations for next year, so just kind of bear with me for a second, because again, it is so important to understand that you have to start looking at it now, even if it may not come to fruition for 2 years, because they could go back to this year or 2018 as your base year, and then 2020 would be your performance year, and you would either be paid or fined the next rate, which I think is 5% when it gets to that level. All right, so they're considering a measure, total change in ADL, IADL performance by an agency patient. You know, we don't do very much with that. I mean, we don't look to see whether they went from a 4 down to a 1 or from a 1 to a 4. So they're considering a measure that will actually do that. Again, way back when in OASIS, before 1 and 2, they had the prior column and the current column. And this is kind of back to that, I think. It captures all three potential outcomes for home health patients: stabilization, decline, and improvement. All right. The measure would also improve accountability during the episode of care when the patient is directly under the agency's care. The measure would report the average normalized total improved functioning across 11 ADLs or IADL items on the current OASIS C2 instrument. The measure is calculated by comparing scores from the start of care or the resumption to the scores at the discharge. Keep in mind that that's two different time points: start of care to the discharge or the resumption to the discharge. So you want to make sure, because it needs to allow for maybe some decline when that patient was admitted. All right. Considering a composite functional decline measure, that could be the percentage of episodes where there was a decline on one or more of the 8 ADL items used in the measure, would enable an agency's efforts to improve care and prevent functional decline for all patients, including those for whom improvement in functional status is not a realistic goal. So when they're looking at the composite of it, because some of our patients are never going to get better, so it's unrealistic to think that we can set a goal of them being functionally independent. And again, the agency would receive credit when there is no decline at discharge. Right now, some of you may be aware that stabilization really kind of dings you when a patient doesn't get any better. That's just about as bad as a decline in our outcome measures right now. All right, considering adding a agency correctly identifies patient need for mental or behavioral health supervision, and they're going to do that by with some of the items that's already there. So it captures a patient's need for mental or behavioral health supervision based on an identifier, assesses whether the agency correctly identifies whether or not the patient needs mental or behavioral health supervision based on the OASIS start or the resumption, item 2102F, types and sources of assistance, supervision and safety. So some of you may remember that the 2102 items were part of value-based purchasing last year, but they realized with that big item, it was really kind of hard to do a measure on that. What were we comparing it to? They really didn't have anything else to compare it to. So with this, considering that item, they would get most of it from 2102, but there would be a new item for identifying that patient. All right. Considering including caregiver can and does provide patients mental or behavioral health status. So again, it will have to do with 2102 also. This measure would encourage agencies to ensure that patients who need mental or behavioral health supervision are receiving such care from the patient's caregiver, and would be a realistic care goal. All right, HCAHPS. All right, so what's going to happen with HCAHPS? So adjustment to the minimum number of completed home health care consumer surveys. They're going to be using a minimum of 40 completed HCAHPS surveys rather than a minimum of 20. And they think that this would better align the model with the HCAHPS for the patient survey star rating on Home Health Compare. And this change should have a more positive impact on your agency's total performance score, meaning that the more you have, the better your score should come out. When you've only got 20, then obviously your numerator is going to be much smaller, so your answer is going to end up being much smaller. I just wanted to say this, and when I got to this point here, I remember this as I was thinking. People often, especially those in the value-based purchasing states, will say, how can I control this? Or how can I improve this? Well, you cannot do much to influence what somebody writes on their surveys, and what they write will be tabulated and will automatically go into your outcomes. But what you can do is just to make your patients aware that they will be receiving a survey and letting them know that it is okay. We want you to fill this out. We sometimes find ourselves telling our elderly population to be very careful. Don't fill anything out. Don't sign anything. Don't give anybody information. And a lot of people take you very literally. So when these surveys come, then they trash it. They put them in a trash can because they don't know who it's coming from. So it is, I think, a good practice for clinicians when they admit the patient, and even remind them when they're getting ready to discharge the patient. Remind them that they are going to be getting this survey. We have sanctioned that survey. We want you to fill it out. We want to know what we can do to improve. And that way they would be more likely to take this survey and get information to you. And remember the old adage that when somebody is really happy with your services, I'm sorry, when they're not happy with your services, they will tell everybody they know. But when they are happy, they very seldom go out and tell people about it. We want them to tell people when they're happy because it makes a difference in how they're going to answer it. So you need to remind them that they're going to get these things, and that we will be asking them to fill it out. Hopefully your vendor, whoever your vendor is that you use, has if they send it out, if they send a paper base, or if they call, they are mentioning your agency's name, so that patient or the family member knows that your ABC agency sanctioned this, and it is okay for me to give them this information. Because some people, as they kind of get a little bit hesitant to give out information on a phone call to someone that they don't know. So if you tell them that, they're more than likely to participate in the survey. Okay, so what I did here is, this is the link for the rule. Again, it is probably 300 pages, 280 to 300, something like that. I don't expect that most people are going to read it, but it's there. You should have it. Put it on your desktop. You can always refer back to it. And now it is actually official. It is in the Federal Register, so everything that's here will come from this rule for another year. All right, and so your vendors will be using this also, or worked diligently yesterday to make sure that all these new rates are in their software, so that when they calculate your HERG or your reimbursement on an admission that you just did, that it will be for the 2018 calendar year. So now let's say, again, if you admitted a patient yesterday and you discharged them 60 days from now, that's going to be before January the 1st. So none of these new rates that we put in, that we talked about today, will be effective. They will still go on the 2017. But if you admitted a patient yesterday and you finished it today, and today is your MU 90 date, that's what you're looking at. That will be depending on the 2018 calendar year for the calculations of your payment, your standardized rate, your non-routine supplies, and any of that. And also that case mix adjustment variables and scores, and that other the clinical and functional threshold will be based on the 2008 version also. So for those of you that choose to read this, happy reading, because it's not very interesting to read. But you may be able to peruse it and pick out, go to find in your PDF document and find the particular topic that you're looking at. Go in and read those few pages, mark it so that you can go back and look at it. Because a lot of the stuff in that rule, I have to tell you, is historical data. They tell you what they did, why it was done that way in 2010 or 2012, and then they come all the way up to, so in 2018 we decided to do this. So most of it is not applying to anything that's new. It's just basically historical data. But it's something that you may want to have in case you have some questions about something later. So I anticipated this would be relatively short because we took out all the HHGM. I had to take a lot of slides out because the HHGM did not go. But that's good because I don't think anybody would have been ready for it next year anyway. So Rob, that's all I have. I can take a few questions if anybody has any.
That's wonderful. Thank you very much, and thank you for putting this together. We appreciate it. Yeah, just a few questions. There's a few specific ones that we should probably just take offline, but someone just asked, just to confirm, when will we need the new OASIS forms? Are they changing in 2018 or 2019?
2019.
Mm-hmm.
Yeah, so this year there's no changes on the OASIS. They're actually, for just so a little bit more than the final rule, there's no changes that have been made to the final, the OASIS. The only thing that I can tell you that's probably of significance in the OASIS this year is they made some adjustments to what their definition of the one clinician rule is, and who and when you can have two different people contributing. Still only one person can fill it out, but that's the only change. In next year in October, though, if they don't decide to extend that rule that they've made final, they could extend it. Then in October, we should be introduced to the new OASIS, and it will be effective in January. Okay.
And then, well, we're getting a lot of questions. Is this webinar recorded? And the answer is yes, and we'll send you out a recording link within 48 hours here. And I think that's going to be it, Jennifer. Thank you so much for the presentation. We greatly appreciate it.